Hello and good evening to everyone. And we hope that everyone is enjoying this fascinating conference on public health. So we are at that time to have our first panel discussion. And the mechanism will be as follows. We would have introductory remarks by each of our panelists. They will present a brief presentation, and there will be a section afterward for question and answer. And we're hoping for some fine engagement with everyone that's present today. So our first panelist is Dr. Colleen Radix. Now, Dr. Radix is a SGU alumna. She completed her medical training with a combined internal medicine and pediatric residency at Brookdale Hospital in Brooklyn, and Overlook Hospital in Summit, New Jersey. She later obtained a fellowship in occupational medicine and environmental health, during which she completed an MPH degree. So as a board certified public health physician, she has accumulated a wealth of experience in public health from her time in academia, serving as chief medical officer in Tobago, along with her consultancy with numerous regional and international public health agencies. She is currently the head of health and the head of human and social division at the OECF. So it's my pleasure to invite Dr. Radix to the virtual stage, and we want to give her our undivided attention.
Thank you so much. I'm not sure if we had a switch up. I feel like we had a different order in terms of our panelists. So just confirming, am I the one? Should I go ahead? Okay, great. Okay, so I'm just going to share my screen quickly. Our panel discussion is really looking at social justice and inequity. And one overarching area related to this is the digital divide. I've been listening closely. Let me just start by thanking St. George's University for inviting me to participate in this panel. It's always nice to be home, being both an alumni and a former faculty of the university. And it's clear that SGU is currently on the leading edge of the digital response with regards to COVID-19. But the digital divide is very real. So just give me a moment here. Let me share my screen. Are you able to see the presentation?
Yes, we can.
Great. Just give me a moment here. Make sure that I am. Okay. So I have a quote on this page here that was delivered by then President Bill Clinton of the United States, now 20 years ago. And it is just as relevant today as it was then, maybe even more so. And he said it's dangerously destabilizing to have half the world on the cutting edge of technology, while the other half struggles on the bare edge of survival. The issue of the digital divide has been one that has been ongoing and really speaks to the inequity in access to the internet and all that it brings with it. So this information, which has been taken from a report, a UN report, which quotes the ITU as a source, shows some differences in terms of regions of the world and their connectivity as of 2019, just before, obviously, this unusual year of the COVID-19 pandemic. And so you can see differences from the high 80s in the developed world to 19% in the least developed countries. And what do we mean here by a lack of access? Because access doesn't just mean whether or not you have access to the internet. It could mean what kind of devices, if you have devices, how many devices and what kind of devices you have. It could mean what is your capacity in terms of using devices or using the internet for your needs. And it could also include what is the bandwidth and what is the connectivity where you are. So all of these contribute to inequity. Along with the issues around inequity, in terms of access to all the things that the internet has to offer. There are also challenges that go along with accessing the internet, which can also be increased in areas where there's lack of access. So there are issues around privacy, security, and even things like cyberbullying around children and the use of the internet. This is an ongoing topic, obviously around the world, and COVID-19 has accelerated the global response to collaborative solutions. Here we have 3 different documents that have been produced just this year in response to COVID-19, the World Bank Digital Development Joint Action Plan and Call for Action, the World Economic Forum talking about accelerating digital inclusion in the new normal, and the Roadmap for Digital Cooperation coming from the United Nations. And all of these documents speak to what we need in order to close the divide. Connectivity, devices, the fact that access needs to be a right. We need to improve capacity and safety and security, as has been said. But I want to take a moment to highlight the fact that the digital divide has further accelerated with COVID-19, and it's a spiral, upward or downward, depending on what you have access to. The digital divide has affected all spheres of our lives. If you have a job, where your children go to school, if you're an entrepreneur, all of these things have been affected. Persons with certain types of jobs have been able to hold on to their jobs because their companies or their workplaces have been able to go to telecommuting. But persons with other types of jobs are now experiencing job loss because the work is not able to be done by telecommuting, and or the companies don't have the ability or the wherewithal to be able to shift. Online schooling, again, the divide in education between those who have and those who have not. It's been shown now that we're working from home, we're schooling from home. The number of devices and the amount of bandwidth you have at home makes a big difference to how you're able to interact in these spaces. What are kids able to see? Are they able to see videos? Do they have access, or are they sharing a device with a parent who needs to be working from home? Issues around methods of pay and safety now around going out. Do persons have to go to the banks, or are they able to access online banking? And for our entrepreneurs, those who already had access to digital technology have been able to shift in this new normal more easily than many of the small and medium enterprise businesses and small retail businesses that have had to close their doors. And then connection, a basic human need. Those who can use the technology and have the technology have been able to stay connected. I personally have been able to stay connected with my family through Zoom and other meetings that have become more regular in this COVID-19 time. What happens to persons who become more and more isolated? And how do these things connect with each other? Mental health, isolation, job loss, how does that contribute to issues of poverty, violence, etc.? And those who are already at a disadvantage tend to be the ones without access, persons with disabilities, for example, in our older population. So these, while some people are spiraling up, others are spiraling down in the context of the new normal. I wanted to take a moment here to say then that when looking at creativity and innovation in relation to the digital divide, we need to look at more than just what's been asked for in all of the documents that I've shared around increasing access, connectivity, devices, and capability of persons to use that technology. But at the same time, we need to be using basic technology again, telephones, text messages, megaphones, community reach out. We need to be having boots on the ground around service providers, because in communities that are disadvantaged, often the persons providing services aren't as savvy with the use of technology. So the teachers who are in a disadvantaged space may not have had exposure to digital technology, and there's going to be some time while they learn. Similarly with healthcare providers. And then information. In this COVID-19 time, information has been going online through the internet. Persons don't have access to up-to-date information if they don't have access to the internet. Just a snapshot, the WHO did a study and looked at disruption of services for persons with non-communicable diseases. And just to say that COVID-19 has disrupted services. And depending on the phase you were in the pandemic, the more disruption there was to services. So some of the things included closure of screening programs, issues of transport due to lockdowns, the fact that staff is redeployed elsewhere, closure of clinics, insufficient PPE for persons out on the ground, and patients not presenting. And of course, because of the supply chain stockouts of essential medicines and diagnostics. So all of these things have been recommended and are bases for creative ways for us to tackle this. Telemedicine, and that means many things. Many things are happening via WhatsApp now that couldn't happen, that can't happen in person. But of course, that opens up the issues of confidentiality, privacy, etc. Task shifting, again, having boots on the ground when health professionals may be redeployed. Novel supply chain, delivery services, the ability to triage and to redirect persons to other sources. I just wanted to take a brief moment to mention some of the things that are being done in the OECS. The OECS Regional Health Project, a project which was designed to look at infectious disease outbreaks and is supported by the World Bank in collaboration with CARPHA, the Caribbean Public Health Agency, was approved in August 2019. And that was just in time, I should say, in terms of the response to COVID-19. Some of the things we are looking at include being able to have a better digital handle of our health human resource and to be able to shift human resource between countries. The ability to increase our pool procurement. We've been doing pool procurement of pharmaceuticals for over 30 years, but being able to increase lab supplies and other things through our pool procurement mechanism. We also have the Caribbean Digital Transformation Project, which looks at many of the things mentioned before around connectivity, access. We're working with UNICEF and ITU around the GIGA project. And then we are also looking at social protection. Can you take this one? Sustainable digital beneficiary lists and digital cash transfers, so that governments are able to find the people who need assistance and get assistance to them digitally. So I'm going to stop here. This is a panel discussion, but I just want to leave with you that in terms of public health and public health programs and how we teach persons to address issues of inequity as part of public health, we need to look at this digital divide and look at the creative and innovative ways in which we can, through programming, reach persons on the ground through the different levels of technology and increase capacities in communities as part of the process of improving public health.
Thank you very much, Dr. Radix, for this fine introduction to our panel. We're certainly looking forward to the continuing discussion on these issues related to equity in our delivery of public health. So now let's go on to our second panelist. This time we will be listening to Dr. Shanti Singh Anthony. Dr. Singh has worked with the Guyana healthcare system for over 20 years. She has worked in academia. She was a member of the team that took the lead in developing the Master of Public Health program at the University of Guyana. Additionally, she has been involved with programs designed to provide primary healthcare services to rural communities and has directed the National Tuberculosis Control Program, and the Guyana's HIV program, working closely with multiple international partners. In 2016, she took up the role as Knowledge Management Coordinator for the Pan-Caribbean Partnership Against HIV and AIDS in collaboration with Johns Hopkins University. Dr. Singh, you have our attention. We welcome you to the stage.
Thank you so much. Thank you so much, Dr. Mitchell. Okay, 1 second. All right. So it's my pleasure also to be here and to share with you this afternoon my knowledge and my experiences working in public health and being part of the Caribbean response to HIV, and particularly at this time to COVID-19. I think that this conference is timely and relevant to all of us as public health practitioners. It has been more than 8 months since the World Health Organization declared COVID-19 as a pandemic. And we've seen how it has impacted on all aspects of our lives, but more importantly, I think we've seen how the global community has mobilized to respond to this pandemic. As public health practitioners, we've been on the front lines, and we must continue to do so. 8 months and more into the pandemic, and as expected, we have a better understanding of the virus and how it works. At the same time, we're seeing that there are really very important intersections between COVID-19 and other important public health issues such as gender-based violence, mental health, and others that really exacerbates the social injustices that already exist. And in that regard, my presentation this afternoon with you will focus on some of the innovations around HIV and how we've responded in the region to ensure that particularly those vulnerable populations and people living with HIV continue to access services while preserving at the same time their human rights and dignity. So as a quick outline, I will provide a brief status of HIV in the Caribbean, very brief. I know most of us know this. I will speak to some key elements of social justice and how these were applied to the key populations and people living with HIV in the Caribbean. And based on these, the innovations that have emerged, and I will close with a few closing thoughts and the way forward. So as a gentle reminder, HIV is still the second most affected region. The Caribbean is still the second most affected region after sub-Saharan Africa. There's an adult prevalence at the end of 2019 of 1.9% with an estimated 300,000 people living with HIV in the region. In relation to new infections, the Caribbean has seen a 29% reduction in new infections from 2010 to 2019. From 2010 to 2019, with an estimated 13,000 new infections occurring in 2019. We also know that while the epidemic in the Caribbean is considered a generalized epidemic, that they are concentrated epidemics among key populations who are at higher risk for acquisition or for transmission of the HIV virus. For example, if we look at HIV prevalence among the population of men who have sex with men, we can see that that is in Jamaica 29.8%, in Trinidad and Tobago 26.6%, the Bahamas 19.6%, and Suriname 16.6%. Similarly, for sex workers in Suriname, the prevalence is 10.3%, Guyana 6.1%. And for transgender persons, the prevalence is 8.4% in Guyana and 51% in Jamaica. In 2019, if you look at a graph that speaks to UNAIDS Special Analysis 2019, you will see that these groups and their clients account for approximately 47% of new infections in the Caribbean, while the rest of the population accounted for 53%. So clearly, these groups are disproportionately affected. and are affected, and this is also linked to some of the social injustices, the legislative and the policy environment, stigma and discrimination that continues to be very pervasive in our societies, including amongst our healthcare workers, and this really impedes access to services. AIDS-related death has declined by 37% from 2010 to 2019. And finally, how do we monitor progress in the HIV response? And this is measured by the 1990 global targets. And looking at the last graph that came up, we can see that as a region, we've made progress. In relation to the first 90, which is the percentage of people living with HIV and know their status, this has actually increased from 61% to 77% from 2015 to 2019. Similarly, on the second 90, the percentage of persons who know their status and are on treatment has moved from 71% to 81%. And for the third 90, the percentage of persons who are on treatment and are virally suppressed has moved from 70 to 80%. So the bottom line is we've made progress, but the gaps are still very significant. And therefore, HIV policy and programming has to be accelerated to get us to the end of AIDS, or to get us to really ending HIV and AIDS as a public health threat. COVID-19 has now come on board, and it really has the potential to derail progress further. And therefore, focusing on addressing the intersections between HIV and COVID, and in so doing, ensuring that there is social justice, particularly for the key population, is extremely critical at this time. So as a priority, focus has to be given to key populations, marginalized groups, and vulnerable groups to ensure that social justice during the pandemic and emergency health situations. The Lancet, in an article earlier this year, did say that to effectively ensure that there's practical social justice, that there are 5 key elements that any program, any country, any institution has to really take on board. So to begin with, the issue of self-determination and agency, and the ability to develop and shape and contextualize public health interventions. And so in the HIV context, key populations were important. And it was important in this context to assess their needs and to work with them so that the interventions are developed in a way that it really meet the needs of the key population with respect for the human rights and with respect for dignity. The second element speaks to prioritizing the poor and marginalized, and certainly in the HIV context and in our region, it speaks a lot to people living with HIV and to key population. At the very onset of the pandemic, and based on self-determination, immediate actions such as food and other essential supplies were provided to people living with HIV and key population. In fact, HIV programs made special effort to link these communities to food bank and to other food distribution network. And so COVID relief networks and cash transfers and ways in which support could have been given to the poor and the marginalized and people living with HIV and key population was really prioritized by national programs. The third component that speaks to equity based on the Lancet, as you would recall, the World Health Organization really defines equity as the absence of avoidable, unfair, or remedial differences among groups of people, whether these groups are defined socially, economically, demographically, or geographically, or by any other means of stratification. The Lancet on Equity made specific reference to healthcare services. And in this instance, it was the issue in relation to access to HIV services for key population at the time of COVID and for people living with HIV. As you would know, with COVID-19 measures, these were instituted across countries, across programs, and so access to routine health services became a challenge, and Dr. Radix spoke to that. And particularly, so it became an even bigger challenge for some of the vulnerable populations. So key populations were challenged in accessing prevention, care, treatment, and support services. The HIV workforce, in fact, the HIV workforce was deflected to support the COVID response. Community outreach to key population was interrupted. You had rotation of staff because of COVID-19 measures, social distancing, and other measures really restricted attendance to clinic. Dr. Radix also alluded to the supply chain system that was significantly interrupted, and so programs were challenged in sustaining their supplies, whether it was HIV test kits, whether it was ARVs, and other consumables. And so this had a significant impact on the HIV program, but it impacted more on persons who could not have afforded to access these services privately. And many of those persons are people living with HIV and key population. This really was not an option for them. In relation to the improvements in standards of critical care, this should not really come at the expense of essential care and routine services. Unfortunately, so many of our routine services have been interrupted. Programs like immunization, antenatal care, treatment of malaria, TB, chronic disease management, and of course, HIV. And this, in fact, based on the opinion in the Lancet, could result in more people dying from preventable conditions than people dying from COVID-19. And we know what the death rates are for COVID-19. I think further research post-COVID-19 will give us a true picture of what the impact of this pandemic has been. And then finally, the Lancet spoke to, as we take a closer look at practical social distance, that there has to be a recognition that outbreaks can worsen existing vulnerabilities, inequities, distrust, and implementing of public health interventions. And so it is really very important for authorities to respect human rights and dignity of people as they develop, as public health agencies developed interventions to address these pandemics and emergencies. In relation to key population and HIV, looking particularly at gender-based violence, mental health issues, and understanding the impact of lockdown without transparency, and even heavy-handed policing that impedes human rights of the key population and can undermine popular trust. In fact, going back to the first point of self-determination, trust can be earned by actively engaging the community, going back to the self-determination and agency to develop and support implementation of COVID-19 measures. And so bringing this all together very quickly, especially for key populations and vulnerable persons, it is about access, equity, diversity, participation, and human rights. Those are key elements. In terms of some of the innovations that came up, I think Dr. Radix spoke at length about the digital technology, but online appointments and scheduling really did come up very early in the COVID-19 pandemic. And so from a practical standpoint and looking at social justice from a practical standpoint, these innovations were onboarded very quickly. So technology was brought on board in a very substantive way. And for many, but really it did also begs the question about the whole issue of availability, and particularly for some of the key populations who did not have the means to the technology, whether it was the hardware or whether it was the connectivity. Nonetheless, key populations, communities, they work together for online appointment, online scheduling, for testing, treatment, for counseling support systems. Many of the communities actually used WhatsApp to connect with their healthcare workers, to navigate treatment issues, and to support each other in multiple social issues that they face and they continue to face even now. Many key population networks have also formally established online peer support, what they call online peer support using WhatsApp. The Caribbean has lagged behind in terms of the implementation of HIV self-testing, which is a really proven evidence-based approach to diagnosing more persons. But with COVID-19 and the restriction, the measures that COVID-19 imposed, what we've seen is that HIV testing, the discussion on HIV testing has again come to the fore in the region. And while it's still not being implemented in many of our countries, there's been greater advocacy from the community for this service. COVID-19 has caused us to think about different models of care. And so when we look at the HIV treatment program, what has emerged is differentiated models of care. And so for stable patients, it's a situation where what has come on board is multi-month describing dispensing for HIV treatment, for HIV services. And so for late presenters, it's more frequent visits to the clinic. Learning from HIV treatment programs, what has emerged as well is multi-month dispensing for prevention. And so things like condom pre-exposure prophylaxis has now come up as a new innovation in terms of service delivery for HIV prevention services. In some of our community-based organizations, what we have seen is home service delivery, and so courier service, where in a very simplistic way, they've hired a taxi, and so they're able to deliver treatment to people living with HIV. They're able to deliver the services to people living with HIV. And in many cases also during this pandemic, what didn't apply before, but it's present now, we're seeing that clinics and programs are allowing family members to actually receive treatment on behalf of clients so that they don't have to come out and be interacting at the level of the clinic. In terms of technology, again, at the program level, we have used technology for counseling, technology for training, and technology for really sharing knowledge. So a host of webinars, share, and really be able to share experiences, understand what's happening at the public health level with people who are at risk for HIV and persons who are on treatment for HIV. In terms of going forward, I think it's really critical for the continued engagement of the community, those key and vulnerable communities, so that there can be an ongoing understanding of their needs, their evolving needs, and to be able to use those to develop and to anchor public health initiatives that would best suit and best address the needs of the community, and at the same time being able to ensure that there is social justice for those key and vulnerable communities. Importantly, I think it'd be necessary to evaluate these interventions as we go along, to understand, to decide whether these can be done on an ongoing program monitoring basis, or whether there has to be periodic evaluation so that we can understand whether we can adapt, and we can scale up so that these interventions can be more widely accessible and that more persons can benefit. And I think it would be important for us to be able to document our implementation experiences, including lessons that we're learning at this time, and as these can be really useful in the future, should there be future health emergencies similar to COVID that we may have to address. So I'll stop there. Thank you very much.
Thank you very much, Dr. Singh, for your very informative presentation on the current situation with healthcare delivery to persons living with HIV, and more importantly, highlighting some of these innovative solutions that are being implemented to ensure healthcare is ongoing. Certainly, we look forward to the engaging discussion later with this in mind. So now we are going to turn our attention to Ms. Lori Moyes-Sayers, also SGU alumna, bringing a unique perspective to this panel with her experience on the ground at the Boston Public Health Commission's Homeless Services Bureau. She is currently Director of Community Health Integration at One Neighborhood Builders in Providence, Rhode Island, with a focus on expanding the impact of the Central Providence Health Equity Zone and other community building efforts aimed at eliminating barriers set by social determinants of health. As a woman of Haitian descent, Lori has a history of advocacy and continues to establish relationships with local organizations dedicated to serving those who have immigrated to the United States. Ms. Moyes, we giving you our undivided attention now.
Hello, everyone, and thank you, Dr. Mitchell, for the great introduction. Thank you for allowing me to come in and speak about some of the innovative practices we've been doing here in Providence. Let me go ahead and share my screen so you all can follow along with me. All righty, so today I'll be talking about practical initiatives used to minimize the spread of COVID-19 on a community level. As was mentioned, I'm the Director of Community Health Integration at One Neighborhood Builders here in Providence, Rhode Island. Today, I will start by explaining what the work is that we do at our Health Equity Zone and how it shifted towards more direct service work at the onset of the COVID-19 pandemic. So One Neighborhood Builders is a community development organization here in Providence, Rhode Island. We are focused on housing and affordable housing for those that are in need. We work on establishing affordable housing mechanisms, building and or renting for those that are in our community. We also are the backbone agency for the Central Providence Health Equity Zone. The Health Equity Zones are focused on the social determinants of health of our community and how we can build community through addressing needs that are more upstream. So you may ask what the Health Equity Zone is. Primarily, I will say that it is the first of its kind across the nation here in the US. Health Equity Zone started in Rhode Island, which I'm very proud of, and to be a lead organization that is a force to be reckoned with, I must say, in addressing social determinants of health. So Health Equity Zones is a model that was created by our Department of Health. And the focus is working with the community, meaning that we connect with community members on a day-to-day basis to address their daily needs. We also work with other community organizations and municipalities to address some of these needs. This is a grant-based model. It runs for 4 years, and I've listed the theoretical land front of how we would address these needs. We host and establish needs assessments in our communities. And we talk with community members by way of focus groups, telephone calls, text messages for our first year, just to hear what's going on, what's on the ground, what are the health disparities that our folks are facing. And we work together in a collaborative effort amongst, community members and also community organizations that we work with to motivate upstream change directly with the Department of Health and other municipalities. So with that said, I wanted to share a little bit of demographic information to capture what COVID-19 looks like in Rhode Island. So first of all, I wanted to share that the state of Rhode Island is in the eastern north side of the United States. We have an overall population of about 1 million and some change, give or take 50-50 male or female. And we also have a annual median household income of $63,000 and some change USD. I want to highlight the race percentages for you all, just to give you a little bit of background. We have about 71.5% of our 0.4% of our constituents that label themselves as white. We have about 16.3 Hispanic and 8.5 African American, 1.5 American Indian, 3.7 Asian alone, and 2.9 two or more races. As you can see, there's a big gap between the white population and the people of color in this state. And I want to highlight this as it definitely shows true in our COVID-19 rates. Another thing that I'd like to highlight is the life expectancy chart here in Rhode Island. Highlighted here is the Providence neighborhoods where we are working as the Central Providence Health Equity Zone. As you can see, there is about 75 age difference and 75 to 78 years of life expectancy in the Providence location. And right next door, as you can see in the darker areas, Cranston, which is about an 8 or 9 year difference, which is huge, right? As you can see, these neighborhoods are really close and we want to know what's the difference. Why is it that Cranston, which is right next door, has a higher life expectancy than those that are in the Providence neighborhoods. And as you all know, in the public health field, we know that life expectancy stems from many disparities and also social determinants of health, whether it be what race you are, how old you are, what education you have, what housing model that you currently live in, and also your socioeconomic status. So jumping in a little bit deeper, just to paint the picture, our folks in the Central Providence neighborhoods are about 53% speak Spanish. About 50% of our folks are of Hispanic descent. And that is very interesting to note, as I mentioned, there wasn't that big of a population of Hispanic persons in Rhode Island itself. Also, we see that there is less than $25,000 as the household median income, which is very different from the 63 that we mentioned earlier, right? So just to paint a picture, there's a huge disparity in our community in Providence. And when COVID-19 hit, we saw it straight away. As many of you know, COVID-19 has impacted folks of color, folks of low socioeconomic status, drastically as compared to those of our white counterparts. So COVID-19 in Rhode Island, as you can see, we have the circled Providence once again and a darker color, which means we have been hit with COVID-19 a lot more than our neighboring communities. And I've listed a few demographics here, but I do want to highlight primarily the Hispanic or Latino population and Black or African American have been hit terribly hard with the COVID-19 pandemic, although we only make 35% of the state's population. One can infer that a lot of it has to do with social determinants of health, the chronic disease that folks of color struggle with, socioeconomic status, race, all of which contribute to the numbers associated with COVID-19. And one would say, how do we address this in an area where there's a lot of backhand things that go into why COVID-19 is prevalent in folks of color? We see that, the chronic disease issues that we have here, we struggle with a lot of diabetes, we struggle with housing insecurity and also socioeconomic status. So we met as a health equity zone with our Department of Health and tried to think of tactful ways to address public health education, getting all of the resources out there for our communities that were disproportionately suffering from COVID-19. So we came up with 3 frameworks and 3 tactful efforts in order to address COVID-19 in our area. One was to increase the testing in our zip codes. Secondly, increase the effectiveness of contact tracing, meaning breaking that stigma, right? There's definitely some hesitation to share your information with public health officials when it comes to contact tracing. But we all know that contact tracing is a big effort in way to minimize the spread of COVID-19. And also ensuring that quarantined individuals that may not have all of the resources that they need at hand are allowed the resources that they need in order to quarantine successfully with their families. So how did we do this? As you know, there are definitely many things that impact our communities, and we wanted to make sure that we did this in a direct and successful manner. So first, we wanted to disband as many community health workers as we could. By way of volunteers, paid community health workers, and those that are vital voices in our community. Expanding this community health worker network allowed us to get into our community members and being able to communicate with them directly. The primary focus of expanding our community health worker network was to ensure that folks that lived in our community, folks that had voices in our community, were able to connect with folks that looked like them, spoke their language, understood their cultural makeup in order to break some of the stigma that went along with COVID-19 and understanding the implications of ensuring that you are isolating and quarantining safely. What resources are out there? How can we address your need at home by way of our community health workers. So that was one of the first things that we worked on. Creating a cohort of individuals that live in the community, that understand the neighborhood, that look like the folks that are in the neighborhood in order to bridge that gap between healthcare and the community. We also focused on communications. I remember we were discussing around the digital divide. This was a big piece in establishing our communications plan. Knowing that many of our residents may not have access to the internet, to telephones, we had to create communications across the board via telephone, text messaging, direct mailing. We also did radio ads and television pieces in order to get the messaging out there in various languages to the folks that look like the folks that we're working with. We also supported existing work in the community. Oftentimes, folks that are of low income or may not have the resources or access are unsure what's out there. They don't know where to go for the need. So we worked directly with many of our organizations that are part of our health equity zone to bring that to light, but also share it with our community members by way of our community health workers. There were folks ready and willing to volunteer to drop off meals, other PPE, cleaning supplies, anything that we could get our hands on, we were able to share with our community members by way of our communications. And also mask distribution. We know that masks are super important when we come to decide, where do we put our efforts and our funding? Masks are also very expensive. So we had to think about ways to leverage how to get these masks out into the community, but also purchasing them so folks don't have to pay. As I mentioned, our community is very low income. And right now we've been able to disband over 200,000 masks to our community to ensure that they have the proper items to eliminate the idea of sharing and having to reuse masks over and over again. So those were the 4 things that we've done in a practical sense to minimize the spread of COVID-19 here in Providence. And I believe this can go across sector, across state, across agencies in order to address it at a low cost, but also bring up the inequities that are currently happening here with our COVID-19 rates. That is all I have for you all today. I am excited to continue this conversation.
Thank you very much, Ms. Moyes. And we are excited to continue this conversation as well. We look forward to hearing a bit more about those approaches that have been used to break down the barriers to health equity in Central Providence. So now we are going to listen to our final panelist, Dr. Brian Butler, also SGU alumnus, board certified doctor of veterinary medicine, and he brings a new research perspective to this conversation. Dr. Butler holds a PhD in comparative pathology from the University of California, where he was a recipient of the T32 training grant. His postgraduate research was focused on the development of a translational mouse model to investigate the impact of Plasmodium co-infection on mucosal immunity in the GI tract. He is currently a professor associated with the School of Veterinary Medicine here at SGU, and his current research interests are focused on mucosal immunity and the host response to bacterial pathogens. Dr. Butler, you have our attention.
Thank you, Dr. Mitchell. Greetings to all. It's great to be a part of the conversation today, and thank you for the invitation. The chosen topic, hopefully you can see my shared screen, is public opinion and stigmatization of healthcare workers during the COVID-19 pandemic. And unlike my fellow panelists, I have absolutely zero work experience on this topic. I have zero expertise on this topic, but not to worry, because I think this is a good conversation for experts and non-experts alike to have, because it's so far-reaching and it affects all parts of our community. So what I'd like to do is just begin by introducing some daily observations of stigma that I've seen and Sorry?
Tell everyone about.
Daily observations that you've probably observed as well. Then talk about perspectives from the recent peer-reviewed literature on this topic. And then briefly look at some analysis and impact and what approach we can take as a society to address this problem. So most of you are probably aware of this. You've seen this in everyday life, direct observations of stigma towards healthcare workers. I chose this topic because I started to see concerning headlines, but I also had family members affected by this, and it's really troubling to see the outcomes of this. So depending on which news feeds you consume and headlines that you see, you're probably starting to see some impact of this, no matter where you are, because reports indicate that this is happening globally. If you do just a simple Google search for healthcare worker stigmatization and COVID-19, you're going to realize very quickly there's over 2 million hits, and this is becoming a very, very widespread concern, and it's getting a lot of attention, but only more recently. If you dare to dive into social media on this topic, you're going to realize that there's a lot of information out there as well, some of that true, some of that untrue, and you'll realize that this problem can be exacerbated or inflamed by social media spreading untruth and worsening some of the effects that people have due to this stigmatization. I've done a little bit of review of the literature on this topic. Like I said, I became interested in this when family members were affected and I started seeing the headlines. And as of this morning, if you do a PubMed search for healthcare worker stigmatization and COVID-19, there are just 17 results that pop up. And you can play around with the wording and get a little bit more here and there, but really focused on how healthcare workers are impacted. It's early in the peer-reviewed literature. If you go through Google Scholar, you're going to see a lot more as expected, but still, it's about 9,000, and it tells us that it's early in this body of work, but it's growing. So I think we can expect to see over the weeks and months to come a lot more work and a lot more peer-reviewed literature on this topic. I think societies around the world are starting to recognize that this is a problem to address before we lose the people that are keeping us safe. So here's one example from Lancet this year. Healthcare workers are facing stigma and discrimination worldwide. And if you're interested in this topic and you don't mind reading some of these things, have a look at this paper. It provides a lot of examples of things that are happening in many different countries around the world. And some of the examples brought forward include harassment and even physical assaults of healthcare workers. We're seeing examples of doctors and nurses that are being denied access to public transport. Really horrific things if you think about this and if you witness this. Even eviction from rental apartments. And I'm sure, as you can imagine, social media bullying and harassment. And to think about the impact on the healthcare workers that this might have is staggering. Another source that I thought was interesting is a paper that points to fear and avoidance of healthcare workers is increasing. And this was a survey study in North America with 3,500 non-healthcare worker participants. So not a huge survey, but they did collect some interesting data nonetheless. And it indicated that greater than a third of respondents avoided healthcare workers for fear of infection. And it might seem like common sense to avoid a doctor because he's working with patients or nurses that are working with patients. You think about that, but think about the effect that that might have on healthcare workers. It also pointed out that greater than 25% of respondents believe that healthcare workers should have severe restrictions of their freedoms. So things like being isolated in their homes after they finish a day at work, just really strange, maybe not strange, understandable, but very unfortunate perceptions that the public is having. So we need to really, really investigate this, look into this deeply. That's better. Look into this more deeply to understand this phenomenon. So what is driving this public opinion? I think probably the most obvious cause would be people feel that there's a threat on their individual health. Understandably, people don't want to contract COVID-19, some people more than others. At-risk people certainly can feel threatened about this, but I think there's a lot more to this. Public attitude towards quarantine. Lockdown and shelter at home scenarios in certain countries have certainly changed public opinion. And this is understandable. If you put yourself in different people's situations, you can understand. So if you're having lockdown or quarantine for extended period of time, this has tremendous economic implications on individuals and groups of people. This can have large implications to family life. If you test positive, if your children test positive, or anyone in your household tests positive, your children would not and should not go to school. And this fear alone of having children not being able to go to school is a big cause driving people not to get tested. The social implications would go on and on and on as well. So these public attitudes towards quarantine and lockdown, shelter at home situations is changing as the months go by. And a lot of people are really suffering. Small business owners are feel very threatened in their livelihood because some people are losing their businesses. There's also a changing public attitudes towards wearing masks, and as the longer this goes on, the more and more people feel like their individual freedoms are affected. So there's cultural implications of this. We've seen in the United States there's political implications of this, and this is part of the COVID fatigue that's happening around the world. And it's certainly not helping to thwart the spread of the virus. And it's certainly changing people's attitudes towards healthcare workers. It's their job to continue to encourage people to wear masks, quarantine, isolate when appropriate. Okay, so the impact of healthcare worker stigmatization. Observations and research indicate that this is a growing, widespread, and underappreciated problem. Unfortunately, it's starting to get more and more attention in the news media and in the scientific literature. And this is associated with COVID stress syndrome. And this is having huge impact on mental health, not only for healthcare workers, but especially healthcare workers. And it's hard to imagine that this would not have a tremendous impact on job satisfaction for healthcare workers. Which is a scary thought. If we start to see people moving away from this profession, that's going to impact the health of everyone globally. We need healthcare workers, and we need to keep them satisfied. So effective intervention strategies are certainly needed to protect people and preserve our healthcare systems. I think this is a great conversation to have. I think it's a good discussion for our Q&A. And what are some of the creative and innovative approaches to this social dilemma? Certainly talking about it is the first step, and what we're doing today with this meeting and this conference I think is a great first step. And I look forward to hearing what colleagues on this panel have to say and share, and others as well. Thank you very much.
Thank you very much, Dr. Butler, for your commentary. Indeed, this is an important perspective on the conversation. And that is a conversation, everyone. COVID-19, social justice, equity, perspectives on creative and innovative approaches. Dr. Badesi is going to take the lead on introducing the discussion component of this panel discussion.
Thank you very much, Dr. Mitchell, and thank you to our panel. And just to summarize, at least from my perspective, what each and every one of you would have quite expertly explained to us is that this COVID-19 pandemic would have shined light, essentially placed on the platform systemic structural inequities that exist, whether it's for healthcare workers, for access to education, managing different at-risk groups, including persons living with HIV and AIDS, as well as those who are homeless and underserved as well. So from that perspective, my initial consideration for a conversation is, while these are different elements of our population health concerns, what is the role of a systems-based thinking and a systems-based approach? Because we're seeing where one issue, COVID, is highlighting all of these different scenarios. How can a systems-based approach be used to manage, to respond to these issues? And while you think about that particular question, I would like to use this opportunity to welcome one of our students, or graduate students at St. George's University, to this discussion as well. And we have with us Natasha Puri. Natasha is a second-year medical student studying at St. George's University. She has previous experience as a research coordinator and co-investigator at Princess Margaret Cancer Center. She was also a marketing and external affairs strategist in a Toronto-based artificial intelligence company as well. Natasha really exemplifies innovation as a co-founder of Empathy, which is a startup aimed to eradicate mental health stigmas on university campuses. She actually presented this at the United Nations headquarters in New York, and is also an active volunteer for the emergency department at Bellevue Hospital, especially during the Ebola outbreak of 2014. As a contributor as well to the Huffington Post, a published researcher, and a global health advocate, Natasha is very much dedicated to improving healthcare systems around the world. Natasha received a Bachelor of Science from New York University and a Master's Certificate in Healthcare Leadership from Cornell University. And she's one of our students as well, certainly with a lot of passion and experience in the area of health equity. And we welcome Natasha to this discussion. So the question is, what is the role of a systems-based approach to managing these examples of inequities which COVID-19 seemed to have highlighted?
Thank you for that introduction. I think I can start off the discussion for that first question. I think it's important to understand what systems thinking means. Systems thinking is a holistic approach, and it's an analysis that focuses on a way a system's parts interrelate and how all these systems work together over time. And so I think during the COVID-19 pandemic, we are seeing that the impact of COVID has not just been on our health or on our healthcare system. We have seen the impact on our economy and our unemployment rates. We've seen it become a racial pandemic. We've seen the impact in our housing and public health sectors, as well as education, social justice, transportation, our sustainability sector. And so understanding all of the interconnecting parts that affect the ways in which people are affected by COVID-19 are very important. And so as some of the panelists discussed, data has shown that Black, Latino, Indigenous, and immigrant communities were disproportionately affected by COVID-19. And this is largely due to structural racism. And these are practices and policies that have clearly benefited and harmed groups over time. I know we're at a place in which our zip code is a better predictor of our life expectancy than our genetic code. And these communities that live in perhaps lower income communities, their occupations put them more at risk. Perhaps they're not working in offices that are regularly cleaned, their insurance status, their access to healthcare. Not everyone can afford to quarantine. And so all of these things have impacted how people have been affected by COVID-19 and their healthcare.
Thank you, Natasha, for that. Any thoughts from our panel members as well?
Just like Natasha said, people are more scared of quarantine than they are of the virus sometimes because of the implications that can come. And I think that's what pushes people away and makes them almost out of touch from social programs and systems being able to reach out and help, because they're scared of quarantine and shutdown. And it's necessary for that to stop the spread of the virus, and at the same time people are struggling because of it. And I think that's really the hardest thing to get to, because there's not a lot in between so far to stop the spread of this virus, other than to isolate people and shut things down. And it's really, really tough the longer this goes on.
I have a question, a follow-up question, in terms of the ability for us to respond, but also rise and manage these different inequities that exist. It requires resources, it requires financing, it requires effort. And one of the realities of COVID-19 is that resources are even becoming more limited and even becoming more disproportionate in terms of its distribution as well. So I think the challenge really is, how can we effectively, sustainably, maybe even innovatively and creatively, be able to articulate sustainable approaches towards beginning to resolve these structural systemic inequities that have existed all along, but is being highlighted by COVID-19. And during and post COVID-19, there needs to be some effort, but that effort requires a lot of resources, and that in itself is even becoming more inaccessible. So my concern and my question to you is, how can we mobilize? How can we creatively respond during and post COVID-19?
So maybe I can take a crack at that. Both the questions, the one with regards to systems thinking and this one with regards to how do we mobilize, which I think are related. I think as public health professionals, we are very aware of the systems approach and the way in which we look at and examine problems are holistic, and we understand that everything is connected. Certainly looking at the social determinants of health is one great example of the way in which we do that. So I want to say that the systems approach is extremely important, especially in this time with COVID. But with regards to mobilizing resources, you mentioned financial resources, and then you mentioned effort. And one of the things I am realizing, and I think we're all realizing with COVID-19, is that, and I'm sure it's being realized more in developed countries where the pace of life has been faster, I guess, with the digital technology and the ability to do things faster. It means you do more, and we're busy. And being busy is often a reason why we don't see or we ignore the persons next to us who may be in need or who may need things. And COVID-19 has caused us all to slow down. So I'm saying that to say that it may not just be about mobilizing finances to put into a system that's going busily, but as we're all slowing down, to also look at what's happening around us more closely, being more present in our geographic and our space, and seeing what can be done, and coming up with the creative solutions on the ground to address certain things. So this is where, when we mentioned boots on the ground and basic technologies to respond, I mean, we've had examples, for example, of I think this was in Jamaica, where a teacher basically painted a blackboard in a community where they knew that children didn't have access to internet, and went out there and put things up every day in a way that kids could use distance and get information, for example. And there are examples of that all over on the ground. So I think it may be more effort now than finance, but I think that we need to look, the shift of us slowing down, staying at home, relooking and rethinking can also shift the way we respond to some of these social issues.
Thank you for that comment, guys, and feedback as well. We have a question from Dr. Oles in the chat, and our president, and he actually, in the context of healthcare workers during this pandemic, would have perceivably gone from being heroes to villains, especially within the recent unfounded charge that physicians are intentionally inflating COVID-19 numbers and deaths for financial reasons. Dr. O is seeking a comment from our panel on this particular scenario.
I don't have much to say about this, but I think it's just a completely false comment. I don't think there's any basis for it. Unfortunately, it came from a person of power, and we've been seeing that too often lately. But I don't think it's founded whatsoever. I was reading this morning on the topic of discrimination against healthcare workers, and a lot of headlines and a lot of literature and a lot of just social pop culture and media are, rightfully so, labeling healthcare workers as heroes, and that's great. We all do probably feel like, in a lot of ways, our healthcare workers on the front lines are heroes in this pandemic, and they certainly are. I wouldn't ever say otherwise, but that's having an impact because you're calling them heroes, which we all do. It seems like the logical thing to do, but there was one study I read this morning where that's making it hard for these people to work, because even though they're heroes, they're still going to work every day and people are dying, and it's hard for them to feel like they fit in that label. It's just I can't put myself in that situation. It just seems tragic. So this heroism concept, which we all agree with, is actually, for some healthcare workers, they've stated it's too much, it's too heavy for me. But I think the comment on that unfounded charge is just that, it's unfounded and it's unfortunate.
Thank you, Dr. Butler. Laurie, we have a comment that's connected with your presentation, and this is coming from Roni, who is joining us from California, who indicated that where she's located, there is an initiative called Project Room Key, which is a project targeting homeless populations who also live with mental health and within the context of COVID-19. And their state is working on a project to secure hotels and other living spaces to address some of the needs of homeless persons, especially within the context of the pandemic. Are there any particular examples or efforts on the part of Rhode Island as well that's targeting towards this particular population, homeless persons, mental health, in the context of COVID?
Absolutely, there is. At the start of the pandemic, the state organized many hotel stays for folks that were homeless and that were experiencing COVID-19 symptoms. We still have that establishment with the Marriott Hotel, and also local schools that closed, to their population have also offered space for our homeless population. Primarily in Providence, I will say the hotels have been extremely easy to work with during this time in order to get our homeless population in a safe space. And we also have healthcare space. And on top of that, we have private buildings that have been on lockdown for years that the state was able to open up and put beds there for those and families as well that need to isolate. So not only the homeless population, but we have a lot of overcrowding in the urban community, and families that may want to quarantine but cannot due to the amount of folks that are living in the home, sharing bedrooms, sharing living spaces, also have access to some of these resources as well at both the hotel and also the abandoned buildings.
Yeah, thank you for that.
No problem.
Natasha, we have a question that just emerged from the chat, and this question is connected to the whole aspect of practicing social justice in the context where persons literally have to make a choice between going to work to earn a living while worrying about being exposed and being affected with this life-threatening illness. And that's the reality, and that's a choice for persons on a day-to-day basis. What approaches can we take in terms of the practice of social justice in these occurrences, which is happening in developing countries across the world?
That's a great question. And I think, research now shown that low and middle income countries are simply unprepared for the pandemic. And while developed countries have have the resources and they have pandemic preparedness initiatives. That's not quite the same for what we're seeing in developing countries around the world. If you take India, for example, during the lockdown, 400 million people, informal workers, they were out of work as a result of lockdown. And if you think about the number 400 million, that's larger than the US population. And so all these people now face deeper issues of poverty and starvation, and then naturally the supply chain of food and basic necessities are affected. And so I think in understanding that countries around the world cannot simply social distance, they can't work from home, they don't have those capabilities. And so there is a responsibility for the international community to pay more attention to countries that do need some support. And if we think about, with respect to what Dr. Radix said about effort, I think that's a really important point. We are seeing places and hospitals in the US and Canada, for instance, they are increasing their telemedicine efforts. They have invested so much in community medicine, telemedicine in order to support people throughout this pandemic. And we have to make sure that those resources or those initiatives can be available for countries around the world that need it. Because the information is the same, the evidence is the same. It's just a matter of giving more people access to it. And also a lot of countries use, especially like in Africa, they use mobile phones for communication. And so using things like WhatsApps or text message to get out information is really important. So I think it's almost, again, taking a step back from, we don't need the latest technology. We just need to use basic technology in order to get out information. And on top of that, we're seeing that countries, for example, or developed nations throughout the pandemic, they were able to reschedule a lot of surgeries, a lot of appointments or routine visits that could be done, months later. But in these lower middle income countries, they cannot afford to postpone these type of appointments because there is a risk that more people will die from infectious diseases or infectious causes or other diseases than COVID-19. And so there is sort of a balance of priorities that needs to happen.
Thank you very much, Natasha. Dr. Shanti Singh Anthony, I have a question for you, and this is just based on your presentation. I was wondering, and I have two schools of thought. We have the COVID-19 pandemic within the Caribbean region. Different countries, different governments would have responded in terms of lockdowns, restrictions, a lot of public health regulations in terms of essential and non-essential workers and the limitations that exist in society. From the context of the incidence of HIV infections, how would you project the incidence of HIV infections will manifest itself during this COVID-19 pandemic? One school of thought is that, well, with restrictions, there may be less likely risky behavior. But another school of thought is, well, with economic downturn, there may be more risky behavior. So I'm thinking about what our countries, especially in the Caribbean region, need to think about in terms of projectively planning, in terms of projectively preparing for any type of HIV infection changes during and post COVID-19. We appreciate your thoughts on that.
Thank you so very much for the question. That's a really, really very interesting question. And I think the region in different countries, we've been brainstorming both schools of thoughts. And I think there can be discussion on either one. If you think about the restrictions and how those would have impacted on risky behaviors, we're getting good feedback from some of the key populations, so sex workers, for example. And so there's also two schools of thoughts in terms of their engagement in sex work. So it's risky for COVID, but it's also very risky for HIV. And if you think about the economic downturn, I think what programs have been doing is they've been trying to sort of meet both to be able to address the risky behaviors and to be able to address the economic downturn. And so while countries' national responses have focused on reaching people across the country with cash transfers and those kinds of incentives, The HIV program has really focused on reaching the key and vulnerable populations. And so while there might not be a large community response in terms of delivering HIV services in person, the community has stayed connected in terms of online appointments, being able to have WhatsApp, being able to schedule clinicians visit, those kinds of things did continue to happen. And so I would say as of now, we don't know whether it will have an increase in incidence or whether it will remain the same or whether it will decline. I think what's happening right now is that there is a wave of new strategic HIV STI strategic plans that are being developed across the region, and those considerations are being taken on board with this new wave of HIV strategic plan. And so the discussion has been around if there is an increase in incidence, then how do we accelerate our response? How do we continue to take on board the innovations that we've seen work at this time of COVID-19 and accelerate our response? If there is an increase in incidence, then certainly when we think about the 1990, it's about getting those people tested. And I think innovations like HIV self-testing will really have to come on board in a significant way and being able to link those people into treatment.
Thank you very much for that. And thank you very much to our panelists for sharing their expertise and experiences as we engage a very significant issue of social justice, especially in a time of COVID-19 as well.